1:30. Good afternoon, everybody, and welcome to the last lecture for me with you. I'm gonna miss you around, guys. So, in today's lecture, we're gonna talk about the oral cavity. Again, I'd like to thank Dr. Adil Mohammed for allowing us to use his lecture notes. And the objectives of this oral cavity is going to be how we should be able to describe the oral cavity by the end of the lecture, and the neurovasculature of the tongue, gums and lips, lymphatic drainage, course and branches of the lingual artery, tongue muscles and their innervation, submandibular gland and associated anatomical structures, and the course of the submandibular gland duct, and the innervation and lymphatic drainage of the submandibular gland, and the sublingual gland and its ducts, and the innervation and lymphatic drainage of the sublingual gland. So let's start. Oral cavity. The oral cavity, it contains the tongue and teeth, right? Vestibule. What is the vestibule? Vestibule is this area here, just before the entrance to the oral cavity. So the oral cavity, the proper oral cavity is what's inside. What's inside when we open the mouth and we look inside, that's the proper oral cavity. While the vestibule is this area here, right? Just like this is just like where the anteriorly bounded by the lips and laterally by the cheeks. This area, this is the vestibule. Okay, now the oral cavity proper, as we said earlier, is the space between the below the palate and enclosed by the teeth. That's it. Now the oral cavity proper has a floor, a roof, right? The floor, it's made by these reflections of the mucous membrane under the tongue. And since we are here, we're going to talk about something we are going to do in the lab. In the lab, we're going to open this area here. We're going to remove gently this mucus this mucous membranes, right? This mucosa, we're going to remove it gently, right? So to see the underlying structures. So this is the floor is made by reflections of this mucous membrane, and the roof is made by the palate, hard and soft. And the oral cavity proper is going to open posteriorly to the pharynx, right? Now the teeth. The teeth, we have two types of teeth. The children, like the very little children, small children teeth, those are the deciduous or primary teeth. And each quadrant, like this, contains only these central incisors and these lateral incisors, and then the canines, right? They don't have, when they have their deciduous or primary teeth, they don't have premolars. And when it comes to molars, they have only 2 molars. So if you count, the total is going to be per quadrant here, you're going to have 1, 2, 3, right? And then 4 and 5. Right? So 5 teeth per quadrant, that will give you a total of 20 teeth, right? As the deciduous or primary teeth. Now, when it comes to the permanent teeth, each quadrant is going to have a central incisors, lateral incisors, right? And then canines, and then premolars, 2, and then the molar teeth. So the total is going to be 32. Now the tongue. The tongue has a tips and a margins. The tip is going to be this area, right? So the margins are going to be on each side, as the name suggests. So I'm going to have those margins, and the margins are going to separate the dorsum of the tongue from the inferior surface of the tongue, right? The dorsal from the ventral surface of the tongue, right? So those are the margins on each side, and when they meet anteriorly, they're going to form the apex. Good. So next, what do we have? We have the root. This is the root of the tongue. It's made by this muscular portion connecting the mandible and the hyoid bone, right? And we understand there are muscles going from the mandible, right? And muscles also originating from the hyoid bone. When it comes to the mandible, I would like to mention one information here. It's going to be useful. So the mandible, from within, from inside, it has two genial tubercles. It has a superior genial tubercle and inferior genial tubercle. Why am I mentioning this? Because from the superior genial tubercle, I'm going to have a muscle going from that genial tubercle to the tongue. That's going to be named genioglossus. There's going to be another muscle coming from the inferior genial tubercle, but this time it's going to the hyoid bone. That muscle is going to be named geniohyoid. So now we know why it's named like that. Why it's named genioglossus and geniohyoid. One of them, the genioglossus, is coming off or originating from the superior genial tubercle, and the geniohyoid is originating from the inferior genial tubercle. Now, those muscles, the genioglossus and the hyoglossus, they make the root, right? Now let's move here. The tongue, this is the ventral or the inferior surface. It lies below the tip and margin and contains these two structures: frenulum linguale. This thing here, this is the frenulum linguale or frenulum of the tongue, right? I'm going to have another mucosal fold here. I'm going to call it the fimbriated fold, this one. So I have two mucosal folds. One in the midline, I'm going to call it frenulum of the tongue or frenulum linguale, and another mucosal fold here, I'm going to call it fimbriated fold. And of course, on each side of the frenulum linguale, I'm going to have the deep lingual artery and vein, right? Now next, here we have, again, we are taking another look at the dorsal or the superior surface of the tongue. So it's called dorsum of the tongue, and it faces the palate, right? And it's divided by a V-shaped ridge. Let's look at this. Sulcus terminalis is very important. I need you to know it, maybe for the purpose of the exam. This is your sulcus terminalis or the terminal sulcus. This one here, terminal sulcus or sulcus terminalis. The importance of this, it divides the tongue into two anterior 2/3 and a posterior 1/3, right? The sulcus terminalis or the terminal sulcus is this groove here, V-shaped groove that divides the tongue into anterior 2/3 and posterior 1/3. Now, let's talk about the anterior 2/3 of the tongue. The anterior 2/3 of the tongue contains what we call lingual papillae. The lingual papillae, I'm going to have different parts of them. I have the fungiform, I have the filiform, and I have vallate, right? The foliate ones, I'm going to have them almost towards the margins of the tongue. But mainly, I have the fungiform, the filiform, and the vallate. Now, what's the difference between the fungiform and filiform? Fungiform is a little bit bigger. You are going to feel it like harsher in texture, right? The filiform are very small, so they're smaller than the fungiform, and they are more smoother. Now, in the anterior 2/3, what do we have? We have the foramen cecum. What is the foramen cecum? Do you remember when we talked about the terminal sulcus or sulcus terminalis, which divide the tongue into anterior 2/3 and posterior 1/3? So at the tip of this terminal sulcus here, exactly here, we have the foramen cecum, right? This foramen cecum is nothing but embryologically it's a remnant of the thyroid diverticulum. It's a remnant of thyroid diverticulum, and that is going to have an impact on some congenital malformation like the thyroid cyst, for example. Good. Or thyroglossal cyst. Now, let's continue talking about the anterior 2/3. In the anterior 2/3, again, it has other names like oral or palatine, and all that makes sense, right? Because it's in the oral cavity. Palatine, it's facing the palate, right? And it's the part which is anterior to our sulcus terminalis here, this V shape, right? And embryologically, it's off the first pharyngeal arch. Now, let's talk about the most important information about this anterior 2/3 of the tongue. The innervation. The innervation. The anterior 2/3 of the tongue and the posterior 1/3 of the tongue are different when it comes to innervation. Let's start talking about the posterior 1/3. The posterior 1/3, in terms of sensory and in terms of taste, it's innervated by one nerve. Sensory and taste by one nerve. That's your glossopharyngeal nerve. That's cranial nerve number 9, right? Now, when it comes to the anterior 2/3, in terms of sensory, it's innervated by the lingual nerve. But when it comes to taste, it's going to be innervated by, the taste is going to be taken from the anterior 2/3 through the chorda tympani to the facial nerve. Let's say this one more time. Anterior 2/3 of the tongue. Imagine now I'm putting something like hot in my tongue, right? I'm going to feel pain. So the pain and temperature should be going through the sensory part to the trigeminal ganglia, right? So pain, temperature, and even with my eyes closed, if you put something square or something rounded, I can still know it. If it's smooth or not, I can know the texture too. All that is going to be through the sensory part of the lingual nerve. So the lingual nerve is going to take the sensory information, it's going to take it all the way to the mandibular, the V3, which is going to take it to the trigeminal. So this is the sensory part of the anterior 2/3. Now, in the anterior 2/3, if I just put a salty thing or a bitter thing, right? Whatever, or sweet, right? I'm going to taste it by my anterior 2/3. What will happen? It's going to go for a short distance through the lingual nerve, and then it's going to leave it and go through the chorda tympani and go all the way to the facial nerve. There is a nucleus there in the facial nerve that's called tractus solitarius. You don't need to know it, but that one is responsible for this taste, right? So let's conclude this. The anterior 2/3 of the tongue, in terms of sensory, lingual nerve, V3, trigeminal. Done. In terms of taste, lingual nerve, chorda tympani, facial nerve. Did you get that? While the posterior 1/3 is just done both in terms of sensory and taste by the glossopharyngeal. That's the 9th cranial nerve. Now let's move. The posterior 1/3, we have talked about that, right? Muscles. Muscles of the tongue. We have two types of muscles. We have extrinsic muscles and intrinsic muscles. I like the mnemonic that I created, which is not like very special, but Yeah, I like it, right? So it's GPSH, GPSH, right? So those are the extrinsic muscles of the tongue, right? Interestingly, all of them, they end in glosses, right? So genioglossus, palatoglossus, styloglossus, hyoglossus, those are the 4 extrinsic muscles of the tongue, right? 3 of those muscles are innervated by the hypoglossal nerve. Genioglossus, styloglossus, hyoglossus, those 3 muscles are innervated by the hypoglossal nerve. Except this one, palatoglossus. It's innervated by the pharyngeal branches of the vagus nerve. Done. Intrinsic muscles. The intrinsic muscles of the tongue are 3 types: longitudinal, transverse, and vertical. In this lateral view here, we can see those are the superior longitudinal, those are the inferior longitudinal, and those are the vertical running between them, right? Of course, in this lateral view, we cannot see the transverse, right? Unless we make that cut, right? Which is made right here, right? So in this view, which is anterior view, but the tongue is cut, right? So we can see the transverse type of the intrinsic muscles. So to conclude, we have 2 types of muscles: extrinsic muscles and intrinsic muscles. Extrinsic muscles are the GPSH, genioglossus, palatoglossus, styloglossus, hyoglossus. All of them are innervated by the hypoglossal nerve, except palatoglossus, which is innervated by pharyngeal branches of the vagus nerve, right? Intrinsic muscles: longitudinal, transverse, and vertical. Now, clinical. The role of the genioglossus in maintenance of the airway patency. We need to understand that, first of all, the genioglossus is the muscle which protrudes the tongue, right? Genioglossus, protrude the tongue, right? This muscle, in conscious individuals, everybody around, me, you, her, him, everybody, our genioglossus is in a state of constant contraction. Why that? Not to protrude our tongue, but to keep it from falling to the back of our mouth and obstructing our airway, right? You have seen that in the soccer players, right? When they just suddenly lose their consciousness and they fall down, right? Then what happens? Their tongue falls back, right? And then it obstructs their breathing, and then some of them dies, unfortunately, right? So what happens in conscious individuals, just like the normal individuals, it's in a constant state of contraction to prevent the tongue from collapsing posteriorly and obstructing the airway. In unconscious individuals, if the reason of the unconsciousness is anesthesia, for example, or trauma or injury or whatever, right, this muscle is gonna fall back. That's why anesthetists, before anesthetizing the patients, what they do, they put airway. This is a must. They put an airway first, and then they induce the anesthesia, right? The anesthetist, before anesthetizing the patient, before putting him to sleep, what they do is they give him they put an airway. They put an airway to keep his airway patent. Because otherwise, if they anesthetize him without putting an airway and keeping the airway open, then his tongue, the genioglossus, is going to collapse, and then the tongue is going to fall back and obstruct the airway, right? Now, innervation of the tongue, we talked about that. And then the hypoglossal. The hypoglossal nerve, which innervates 3 of the 4, right? GPSH. 3 of the 4 extrinsic muscles of the tongue. This hypoglossal nerve, it exits the skull through the hypoglossal canal. We remember that. We have our foramen magnum, and on sides of this foramen magnum, right, on each side we have the hypoglossal canal, right? Hypoglossal canals on each side of the foramen magnum for the exit of this hypoglossal nerve. And the neck, it runs between the internal carotid and internal jugular. what I wanted to say, like down here inferiorly in the neck, when you have your common carotid artery and your internal jugular vein, in the middle of them, what is the nerve from there? What nerve runs here? In the neck here, inferiorly, between the common carotid and the internal jugular. That's the vagus nerve, right? That's the vagus nerve. And then when we go up, then the common carotid is going to divide into external carotid, which is towards the face, and internal carotid, which is away from the face and is going to go up, right? Between this internal carotid and between the internal jugular vein, I'm going to have my hypoglossal nerve. So if you want to look for it in your cadaver, right, if you didn't find it yet, just go and follow the internal carotid artery and go up, and between it and between the internal jugular vein, you're going to see your hypoglossal nerve. So, of course, it contains motor fibers to the muscles. Sensory innervation, we talked about that. Arterial supply of the tongue. We have the main artery of the tongue is going to be the lingual artery. The lingual artery is a branch of the external carotid artery, right? It runs deep to the hypoglossus muscle here. This is the hypoglossus muscle, and see how it runs deep to it, like that. And of course, it's joined by a vein. That's going to be your lingual vein, and it gives off several branches to supply the tongue and the palate. Lymphatic drainage of the tongue. The tip is drained by submental lymph node, right? That's why those who have cancer or carcinoma of the tip of the tongue, then to classify and to grade this cancer, they use the submental lymph node to classify and grade their cancer. And the lateral surface of the anterior two-thirds, this one here in pink, right, are going to be drained to the submandibular lymph node, and that makes sense because they are on the sides, right? And then the medial surface of the anterior two-thirds is drained to the deep inferior cervical lymph node, and the posterior to the deep superior cervical lymph nodes. Now, clinical. Malignancies of the oral cavity, frequent site of malignancies resulting from the environmental exposure, especially tobacco products. Ectopic thyroid tissue, thyroglossus. This is what I was talking about. So the thyroid embryologically should be here. If you remember our foramen cecum here, right? So this is the thyroid embryologically here, and then over the time it should migrate from here all the way down to its final destination here, right? So if for any reason this doesn't happen, then it might stop anywhere here in this pathway or passage, and it can give us what we call thyroglossal cyst, right? Submandibular gland. Submandibular salivary gland, because when we say only submandibular gland, okay, I should have corrected this before the lecture, because if anybody just like writes submandibular gland referring to submandibular salivary gland, that's going to be a mistake, especially in the practical anatomy exam, because submandibular gland, right? You're not telling me which one, right? So submandibular salivary gland. It has two parts. It has a superficial part and a deep part. So how do I know which part is superficial and which part is deep? They are separated by this muscle, mylohyoid muscle. Mylohyoid muscle is superficial to it. I have the superficial part. Deep to it, I have the deep part of the submandibular salivary gland. And as we can see here in this section here, this is the skin, this is a subcutaneous tissue, and this muscle is platysma, right? And this is a superficial part of the submandibular salivary gland. So superficial to it, I have the platysma muscle, and then subcutaneous tissue, and then the skin, right? Of course, also, what's not shown here, I think it's going to be a nerve, right? Okay. superficial to, so the submandibular salivary gland itself, we have seen what's superficial to it, right? Let's see what is it superficial to. It's superficial to those guys here. It's superficial to the hypoglossal and lingual nerves, right? It's superficial to the submandibular ganglia and lingual vein. So now we know what's superficial to it and what is it superficial to, right? It's crossed anteriorly by the facial artery and vein, and I believe that you have seen this while you were dissecting your submandibular triangle, the digastric triangle. You have seen how it was crossed by the facial artery and vein, and also by the cervical branch of the facial nerve. What is it supplying? The cervical branch of the facial nerve. It supplies the which muscle? The platysma muscle, right? Because it's superficial, superficial to this part is going to be the platysma muscle, right? So it's crossed anteriorly by the cervical branch of the facial nerve in its way to supply to innervate the platysma, right? Good. Submandibular duct. This is a must-see structure. It's a structure that we must see, right, in our today's lab. It's important for also for the practical exam. Submandibular duct of Wharton. It's same length as the parotid duct. We have seen the parotid duct before when we were dissecting the superficial face. Now the submandibular salivary gland duct, it emerges anteriorly and opens into the floor of the mouth beside the frenulum. So it comes all the way from the depth there, and it's gonna come to open here, right? It's gonna open right here in this caruncle of the submandibular duct here, right? So in your dissection today, what you are gonna do basically, you are gonna remove carefully this mucosa which covers the floor of the mouth, right, to get to your submandibular salivary gland duct. Sublingual gland. Now we moved from the submandibular to the sublingual salivary gland. Before talking about it, I would like just to clarify one concept here. This is your mandible, and in the mandible we have this line. Anybody can tell me what line is this? What is the name of this line? This line here. That's going to be, what do you call it? It gives origin to one muscle. That's mylohyoid line. This line here is a mylohyoid line. It gives origin to mylohyoid muscle. It will originate from this mylohyoid line on each side. It will come to the middle, to the raphe, right? And then unite there, right? To make the raphe. So, why am I saying this? Inferior to it, I'm going to have a fossa. Superior to it, I'm going to have another fossa, right? So, this is a mylohyoid line. Superior to it, I have a fossa that's going to be sublingual fossa, right? And inferior to it, I have another fossa. I'm going to call it submandibular fossa. And here, this is a mylohyoid line with a mylohyoid muscle, right? Separating the oral cavity from the neck, right? Now, the sublingual gland, it lies under the tongue. It's related laterally to the sublingual fossa. So it's going to be right here, right? And it contains several ducts open into the floor of the mouth. So not like the submandibular salivary gland duct, which from each side they open here in the frenulum, right? This one has several ducts, right? For example, one of them opening right here, right? This one here. Next, the sublingual gland is supplied by the lingual artery. That makes sense, and drained by the lingual vein. And we know how they run just behind the hypoglossal muscle here. Drained by the submandibular lymph nodes, in terms of lymphatics. Now, the submandibular ganglion, what is that? Submandibular ganglion is one of the 4 parasympathetic ganglion in the head and neck, right? In COPS, right? We talked about them, right? So it's here. This is the lingual nerve. The lingual nerve is a branch of what? It's coming off what? Which nerve? No. Do you remember when I said Mbala, right? We have trigeminal. Trigeminal has 3 branches, right? V1, V2, V3, right? V1 is ophthalmic nerve, right? It goes to the orbit, right? V2 is maxillary nerve. Through foramen rotundum, we have seen it yesterday, entering the pterygopalatine or pterygopalatine fossa through the foramen rotundum. That's V2. V3 is mandibular nerve, right? That enters through foramen ovale, enters the infratemporal fossa, right? And then in infratemporal fossa, V3 is going to give us Mbala, what I call Mbala. M is going to be mandibular, right? B is going to be buccal, A is going to be auriculotemporal, and then L is going to be a lingual, and then the other A is going to be inferior alveolar, if you remember that lecture, right? So those are the branches of the V3. So lingual nerve here is one of those branches of V3, right? Lingual nerve, as it's coming from the V3 and going all the way to the tongue, in this curvature here is going to be attached to the ganglion, the submandibular ganglion right here, right? Which is parasympathetic. Now, the submandibular ganglion is going to receive parasympathetic from the chorda tympani. So far we know chorda tympani is doing us a favor by taking the taste from the anterior 2/3 of the tongue, lingual nerve, chorda tympani, and then it goes to the facial nerve. This is our chorda tympani. It will do us another favor. It will add another favor by bringing something in. It's bringing the parasympathetic to this salivary glands here, to the submandibular salivary glands and sublingual salivary glands. It will bring them the secretomotor impulses, right? So let's say this again. The submandibular gland purpose is, why is it here? It needs to give secretomotor to the submandibular salivary glands and sublingual salivary glands. When you see something yummy, some food that's yummy or very delicious, right? And then the saliva comes into your mouth, that's because of this submandibular ganglion, right? That's because of this submandibular ganglion, which is gonna send the secretomotor to your submandibular salivary glands and sublingual salivary glands. Now the next question is, from where this submandibular ganglion is getting the parasympathetic? Is getting it from the chorda tympani, which got it from the facial nerve. That's it. Okay? Did you get that? Did you get that point? Should we repeat it? Should we repeat it? Okay. Somebody said we should repeat it. Okay. Chorda tympani. Chorda tympani. What's chorda tympani? Chorda tympani is a nerve. It's off the facial nerve. It has 2 functions. The first function is to take the taste from the anterior 2/3 to the facial nerve. This is the first function of the chorda tympani. The second function of the chorda tympani or chorda tympani, however you want to say it, is to bring in the parasympathetic to the submandibular ganglion, which is going to distribute this secretomotor to the submandibular salivary glands and sublingual salivary glands. Somebody should ask me this question. Now I'm mentioning here, I'm focusing on the parasympathetic, which is secretomotor, which is going to let those submandibular and sublingual salivary glands secrete the saliva, right? Now, what is the rule of this here? Because this ganglion is going to receive also postganglionic sympathetic fibers from superior cervical sympathetic ganglion via facial artery. So this ganglion is going to receive also, beside the parasympathetic, is going to receive sympathetic, right? So what's the purpose of this? Like, how is it going to, like, we know that the parasympathetic is going to make it what? Secrete the saliva. What's the rule of this sympathetic innervation of this ganglion? Anybody, any guess? Simply to decrease the saliva, right? Because in sympathetic status, like if I'm under sympathetic innervation, like if I'm in fight and flight and fright situation, right? I'm fearing for my life. I want to run for my life. At that time, I don't want any saliva, right? So at that time, the saliva is going to be decreased to the minimum or even shut down, right? So when the sympathetic innervation comes to this otic ganglion, to this submandibular ganglion, it's going to decrease the saliva, right? When the parasympathetic in the state of relaxation and enjoying your weekend and eating your yummy food, right? Then the parasympathetic is going to be working at its maximum, right? Now the salivary drainage. Now when these salivary glands are just like sending this saliva, right, towards like the areas under your tongue through the ducts, sometimes it gets obstructed, right? When it gets obstructed and it gives these cystic swellings, right? The technical name for the cystic swellings is ranula. So ranula is the technical name for this cystic swellings due to obstruction of these ducts. Sometimes these obstructions may happen due to small stones. Small stones may form inside these ducts and obstructed and causes this ranula, right? And that might necessitate surgical removal. The end, done, easy breezy. Yeah. So now, do you have any questions before I move to talk about the lab? Yeah, sure. Go ahead. Sublingual. Yeah. Sublingual has several ducts. Submandibular, they have only 2 ducts and 2 openings, right, on each side. Good. So if you don't have any other questions, I want to say a few words about the lab, today's lab. Like my expectations. First of all, I would like you to do 2 types of dissection. A dissection from without, from outside, and a dissection from within, from inside. The dissection from without, from outside. If you remember, when we left this submandibular, right, and submental triangles, we left them just like that. And the last time we dissected that, we visited that area, right? So here we have the mylohyoid muscle making the floor of the mouth from each side, right? And we have the digastric in green here. This is the digastric, right? It has an anterior belly. It has a posterior belly, and they are attached to an intermediate tendon right here, right? Good. And this is the mylohyoid. So what I want you to do today, I would like you to cut this anterior bed of the gastric and then flip it to the back. Then this is your mylohyoid, right? Coming from that mylohyoid lines on each side and coming all the way to the hyoid bone, as the name suggests. What I would like you to do is to cut it from its attachment to the hyoid bone like that. And then just reflect it on the mandible, right? So cut the mylohyoid muscle from its attachment to the hyoid bone and reflect it on the mandible like that. Cut it from here and reflect it there. Cut the anterior belly of the gastric and move it out of your way. When you do that, you are going to see just beneath the mylohyoid, you are going to see this muscle, geniohyoid. When you reflect the mylohyoid, Be careful about that because it's very thin sheet of muscle, right? Muscular sheet. So when you reflect the mylohyoid, you are going to see the geniohyoid. Geniohyoid is nothing but this straight midline muscle going from the which genial tubercle? Superior or inferior genial tubercle? Inferior genial tubercle. This is coming from the inferior genial tubercle coming to the hyoid bone. Genioglossus is coming from the superior genial tubercle and going towards the tongue, right? Do you remember when I talked about the two tubercles? Superior and inferior genial tubercles inside here, right? Superior genial tubercle is going to give you the genioglossus, going from there to the tongue. Geniohyoid is coming from the inferior genial tubercle and going towards the hyoid bone here, right? So this is it. See it, do not cut it, do not touch it, leave it like that. Next to it here, you're going to see another muscle at the same level of the geniohyoid. That muscle is going to be your hyoglossus. That muscle is going to be your hyoglossus. So this is what we are going to do at this level. At this level, we're going to look at those, right? First of all, reflect the anterior of the gastric, mylohyoid, cut it from the hyoid bone, reflect it. Look at the geniohyoid. Lateral to the geniohyoid, you are going to see what? You are going to see your hyoglossus. Now, those pictures, I took them from Nether's anatomy dissection. Now, this is what I need you to see. I need you to see those. To see the geniohyoid. This is, of course, after removal of your mylohyoid. After you remove the mylohyoid, I mean after you reflect the mylohyoid. After you reflect the mylohyoid, you are going to see this. Geniohyoid. Only this. This is a geniohyoid. Right? And lateral to it here, this is going to be your what? Anybody? Hyoglossus. Right? This is going to be your hyoglossus. This one. So geniohyoid, lateral to it is going to be your hyoglossus. And coming from styloid process there, and attaching to the hyoglossus, that's going to be your styloglossus. Styloglossus is a muscle comes from styloid process, right? It's coming from the styloid process there, and the fibers are going to merge with this muscle, with the hyoglossus. Styloglossus is the muscle, the fibers originate from the styloid process. Styloglossus, styloid process, and they're going to merge with the hyoglossus muscle here, right? So yeah, this is what I need you to see in this dissection. Then the next step, done with the one from outside, right? Then look at the bisected head from within, from inside. What I need you to do is do this. I need to see this, right? How is that? Let me go here and come back. As I told you before, right? This is your frenulum, right? And this is called plica sublingualis. This mucosal fold is called plica sublingualis. There is a typo in your lab notes. They have written it as plica semilunaris. That's a structure in the eye, right? It's written as plica semilunaris. It's just a typo, right? But this is called plica sublingualis. Plica sublingualis is just a mucosal fold here, this one. And this is going to be your frenulum. I would like you just to make this incision here. And just try to remove the mucosa here in the floor of the mouth. When you remove it, we're gonna see this. Where did it go? When you remove it, you're gonna see this. I need you to see this. Again, we're gonna take a look at the same muscles, but this time from within, from inside. Those muscles are gonna be in this order: genioglossus, hyoglossus, styloglossus, right? Styloglossus, hyoglossus, genioglossus, right? The final product, one of the most important parts of our today's dissection. I would like to see this. I would like to see the submandibular salivary gland, and I would like to see the submandibular duct, this one, and the lingual nerve. Those are very important. Those are must see. Those two structures, we have to find them today in the lab. whatever it takes us, right? So we need to find submandibular duct and lingual nerve. Lingual nerve, we're gonna see it coming from just behind this mandibular second molar, like from above coming down like that. While the submandibular duct is gonna come from the depth of the mouth. You are gonna see it coming from the depth of the mouth, right? So we need to see those structures: submandibular duct and lingual nerve. Best of luck. See you there. Thank you.